at work, and we would run into each other at the proverbial water cooler, or perhaps talking across cubicles or wherever it might be in the office. We would have these informal conversations among colleagues that can really move the needle in some exciting ways. And trying to outsmart the PowerPoint dynamic, we can kind of really quickly zoom out on. Instead, set up this idea of a cafecito meaning small coffee. Hello and welcome. My name is Dr. Eliana Ramirez. I am the director of the Community Mental Health Equity Project, TA Center. I am honored to be here today with a colleague, Dr. Jay Africa, who is going to talk to us about his really interesting work with the Cultural Competence Plan CCP archival project. In a moment, we're going to start off hearing about Dr. Africa's work at a county level, and then we'll get into talking about the archival work. So I just want to say welcome, Dr. Africa. It's so nice to have you here.
Thank you.
I'm going to just share for a little bit in case this is the first time that our audience has had an opportunity to see a CMEP cafecito, to explain what the cafecito is, and then we'll jump into our conversation.
Sure.
So for folks who are not familiar with CMEP, the Community Mental Health Equity Project, we are funded through AB 74 as administered through the California Department of Healthcare Services to provide training and technical assistance to the state regarding culturally and linguistically appropriate and data-driven services. We work with county behavioral health departments and local community-based organizations to address health disparities at the local level. In addition to providing this TA and training and technical assistance, we are also engaged in a very extensive listening process to the community to hear the ideas from the community, our ethnic services managers and coordinators at the county level, county behavioral health directors, and local community-based organizations and stakeholders about their experiences writing and working on the cultural competence plans. These are written every 3 years, and in between years, the counties send an update on the CCP. The cafecito was designed at the beginning of the pandemic, acknowledging that so many of us really missed when we went into social distance work world, the opportunity to have informal conversations with a colleague, whether it was at the water cooler in the staff room or talking across cubicles in the office. Oftentimes these informal conversations are where a lot of the really exciting innovation and magic can happen. So that's why we're here today, is to have an informal conversation with Dr. Africa about his work in the archival field of the CCPs. Dr. Africa, it's been really powerful to think about how this moment in time focusing on the CCPs really is building upon 40 years of work. That back in the 80s is when, my understanding, and you're going to tell us more, but it was activists and advocates from, I understand, from disability rights movement, as well as Black, Indigenous, and other people of color who were really starting to talk about the importance of addressing health disparities in California. And eventually, several years later, it ends up in legislation through Medi-Cal waiver that established the CCPs. But importantly, there have been a couple of key moments in time over those years since the Medi-Cal waiver established the CCP in legislation that brings us to this point in time where we have an opportunity to make suggestions to DHCS about potential revisions to the CCP guidance, that is the directions that the state gives to the counties and how to write those CCPs. I'd just like to start and ask you to please correct anything that I might have gotten wrong in that very brief high-level description of where we're at.
Yeah, well thanks for that. First I wanted to sort of say that really when I've been doing some digging about really the history and the start of the cultural competence plans, sort of I really got a sense that this is really about the vision of really ensuring that every Californian thrives, especially in the behavioral health setting. That the roots really of why it was intended It was just to ensure that every Californian gets what they need to really be successful. And as California was sort of moving to a managed care sort of delivery system, I think there was some that was through the direction of the federal government. There was, I think, there was a little bit of missed opportunity there of as we were ensuring to shifting the delivery system to really ensure that we still were focused on most of the disadvantaged communities. So I just want to say that, and really the vision, in my opinion, of Rachel Guerrero, who was the chief of office of multicultural services, that brought people together. Researchers, experts, community members, people with lived experience, local behavioral health individuals, and people who really were interested in saying, like, what would that look like to ensure that our delivery system, assures that everybody can benefit and can be successful as they come in to seek behavioral health services, at that point mental health services. So I that really is the poignant piece about this story that I'm trying to put together, that really connected people, brought people together from different walks of life, to really, I think, to put into vision what we now call the cultural competence plan. And I think the issue for me and what I've seen, and I've spoken to quite a number of people already, and I think what are the key takeaways for me is people were passionate about its work, that they had some deep love for the community, that they knew that if we did not elevate their needs, their concerns, their voices, that they would be left behind. And also at that point in the 80s, the United States was really looking at ways to also sort of improve the health outcomes of many people. And so it was sort of what was happening nationally was slowly, I think, being seen as, I would say, sort of the trend. But you have a group of leaders with the vision of Rachel Guerrero saying, well, California has always been progressive. What can we do to ensure that the framework that we use really helps drive that change? So I want to sort of just say that really was the impetus for that. And yet, as California was submitting their state plan to CMS, the federal government, there was a group of advocates who were on that table and said, hey, wait a minute. I want to just make sure that as we're shifting the delivery system, that no one gets left behind. And especially the unserved, low-income, uninsured folks, how do we really ensure that the outcomes for those individuals, those communities, are elevated, and as we move forward to ensuring that all Californians can be successful?
I am so appreciative that you highlight the significant leadership of Rachel Guerrero in not just the beginning, but for many years, my understanding is, and to the CCPs, there is a distinct benefit of having a leader with such vision who is at a state level and creating a table where multiple people are in fact able to join and speak on behalf of those who historically have not had a point at the table. That is a unique kind of leadership ability to be able to create that kind of an environment. And I think about your work at the county level, 2 counties, if I'm not mistaken at this point, in California. And I wonder if you might zoom us back out and just tell us a little bit about the kind of work that you do at the county and how you ended up getting interested in this archival work with the CCPs.
Well, so I been in 2 counties, currently in the county of Marin, and then also previous to that is the county of San Mateo. We, at that point when I came into the county of San Mateo, Prop 63 funds were going to be available, and counties were preparing their plans to say, as we get the Prop 63 money, how do you start really transforming your systems so that you are much more accessible, you are much more culturally competent, you are sort of serving the highest needs, and also be innovative with some of the and solving some of the gaps and challenges that you were seeing in county level. So that really was my sort of entry point. And for me, it's really, and at that point, our director, Gail Batay, really said, I know it's not just cultural competence, it's really looking at the disparities and the inequities that really many of our clients are facing. And really what we can do in our systems to change so that we transform it to be a much more equitable place, right? So that there is no wrong door, so that everybody gets, a say on how they can get treatment or whatever intervention that they would need. So that really was sort of the entry point. And just, having Prop 63 funds really sort of help guide that. And really for me, the one thing that I really learned in that process is how the voice of the community, our clients, people with lived experience, was so important in really crafting those plans and implementing those plans. So, we as safety net organizations and local behavioral health really are focused on the folks that are most unserved, the most disadvantaged, the folks that don't usually get their needs met. And so we, to even equal the playing field, is what do we need to create so that folks can thrive equally with everybody else. And so that I think is sort of the entry point there for me. And I saw the cultural competence plan really as a tool and a framework to create some sort of a guidepost of the areas that we need to focus on: staffing, community engagement, organizational leadership and values. How do we know these issues through community assessments, right? Who's our governing body? How do we use data? How do we improve the workforce? Really, those are sort of categories that I think really the team or that originally created it said, how do you move forward with these milestones? And here are sort of the standards or the buckets of how to do that. And so there's some complexity there because each county is different. Their constituents are different. The residents are different. The needs are different. The politics are different. So it's really thinking about how does that differences and uniqueness apply, that plan apply to the communities that you serve, right? So I feel like that was sort of the vision. And the reality is, oftentimes when you create plans, without really testing it, without seeing how it works, you can have lofty goals, but really sometimes the implementation of that can be really challenging. And that's just, I think, just the reality of this, because as local behavioral health, there's just so many things we also have to deal with, right? And so we do know equity work is super important. It's really critical to move the needle so that everybody gets the same opportunities or equitable opportunities. But with the many, many requirements and compliance and other goals that we are needing to do, how do we really try to embed it that it's really seen as both a part of the work and also at times calling it out and elevating it because it needs to be called out, it needs to be centered, it needs to be put more focus. So I think that's sort of the challenge that oftentimes we're faced. And then I think people interpret those buckets differently, right? People interpret what leadership looks like, people interpret what community assessment looks like. And so people over time, I think, have interpreted it differently.
There's so much that you've just said that is resonating strongly. The first around that the CCP ideally could be a tool that could be useful. And we're having this conversation after having completed 5 listening session events with 2 to 3 concordant listening sessions per event. And we also started to do community-based listening, where we're going out into the community to attend meetings that are in existence. So yesterday, we were fortunate enough to do a listening session, for example, with the Superior Region ESM meeting. It was phenomenal. And what we are hearing across, so this is now 14 listening sessions in counting, and we are so grateful to everyone who is allowing us into those community-based meetings to listen to their conversations about the CCP and what is the role, what is the ultimate utility, and for whom. I think that's a theme that has come up consistently, and it's so helpful to hear your historical perspective of saying this is what was initially intended and where there has been some drift. I also appreciate that you were talking about how important it is that the community drive what ends up in the CCP, and that the ideas of the challenge of creating really lofty goals that are untested. And when you are juggling many different competing or seemingly competing needs that are needing to attend to, I wonder if you could talk a little bit about where some of that drift has happened that you mentioned with some of those buckets. And for folks who are not as familiar, there are criterion in the CCP. I assume that might be what you're referring to. Is that correct? They're based on class standards. There's been some changes to class standards, national culturally and linguistically appropriate services over the years. But I just want to check in with you further on that topic, please.
Yeah, so those are the buckets I thought. So I need to correct you. Actually, the CCP actually came before class. So you already, for me, the vision, I think, and I want to say that story really well, that the behavioral health directors and the ethnic services managers were already creating a framework of how to do the work, right? And then Rachel Guerrero's sort of vision of bringing people together to see like, what will this goalpost, this framework look like, has already been sort of happening. And the Office of Minority Health comes with the class standards a few years after. And what they tried to do, because it was a federal standard, that they tried to merge them together. So that's the story. So the story is the class actually wasn't even thought about it at that point, or maybe they really thought about it, but it's really, when class came, they tried very hard to sort of align that work. And so, but again, that is sort of really the vision. There was a group of people that really were envisioning what will those criteria do we need to have to kind of move the needle in this work, right? And I feel like that's the piece. So, again, I'm only telling a small piece of the story because I was never part of those conversations. I've interviewed and talked to some of those people. And so I think what has drifted is really a lack of guidance on like how these things should be done, right? So there is some, I think, flexibility of how counties interpret it, but I feel like more conversation of like standardization of some of those with a lot of, I think, conversations with stakeholders. I think resources to support the implementation of the CCP is important. Like you can't have a plan without resources that are attached, technical assistance, providing support in terms of feedback, right? So really, really consistent transformational feedback, not just transactional feedback of like, yeah, you did number one, you need number two. Oh yeah, you served 3,500 people, great. And really more in depth of like what you're looking for. So I feel like that's where, and I will say that the reality that local behavioral health has been from the beginning really invested in trying to really improve the health outcomes, specifically of the most marginalized populations, because as the mere fact of being a safety net organization, right? So it's just the demand over time has gotten bigger. And so really balancing how to do that looks differently also for different people. As you know, in culturally responsive services, one intervention, one perspective might align with one community. Go to a next meeting, it says that's not going to work for us. So in a system that really is trying to navigate all of that, how do you create some flexibility that you can tailor it to specifically the audience and who you're engaging with, and at the same time creating sort of a standard metric, right? So here's an example, like when you talk about wellness and recovery looks differently for different people. So can you create a metric on that? I mean, that's sort of the question I'm asking. Well, some we've created locus, we created, some very quantitative data gathering systems. But when you talk about, again, wellness and recovery, for some people, the mere fact that I'm just using less today, maybe, than what I've ever done is a success indicator. How can you measure that? And so I think that's what's happening now, is the framework is needing to shift, and we still have pretty much the same framework that we've used for a few decades. And so how do you now align with the changing times and the changing needs? So that's, I think, really very critical. I also want to say, with many of the listening sessions that you've had, because the work has been done for decades, you have a new group of folks that are coming into a system, that has a really long history, and their perspectives are changing as they're coming in and interpreting what this framework is all about. And so really grounding ourselves to what's the purpose, what's the intention, what's the vision, what's the North Star, and how do we measure that? That's flexible, I think, is a good starting point, because you have, as you probably know, we have a lot of directors that are retiring. Some are new and really sort of new in the field. We have a lot of ethnic services managers that have been in positions maybe for decades, and you have a lot of new ones that are coming in much more really trying to understand the system. So how do you all put that into together so that we're kind of understanding same language, same purpose, same metrics, right? In a changing time. And I feel like there's sort of this assumption that people kind of knew what they're doing. And then layer the politics of your county, the people making decisions about the funding in your county, that also in DHES, shifting their leadership over time too. And this is a fact. Many of the people that are now in DHES's leadership have very little understanding of the history of the cultural competence fund. So and it's not their fault. They're coming into something that they've heard of, read, right? Maybe worked with a little bit, with so little context and little understanding of what it is entailed in created these plans, and then also entailed in doing these plans, right? And so I think that's sort of the challenge right now that we're facing. And I think this is really an opportunity to really kind of step back and be mindful, and versus being kind of reactive about things need to change quickly, and like, what needs to change? How do we measure that? And are those things that we are prioritizing aligned with the different communities and stakeholders, right? I'll just be honest with you. Obviously our people with lived experience, our clients and our consumers and their families, front and center in the heart of our work, communities. But the reality is we have board of supervisors, we have the Department of Healthcare Services, we have CMS that sort of are dictating all of these things. So what's the common ground? What are the things that we really need to agree on? And I feel like we are at that cost, because if we don't think about it that way, many of the people that I've interviewed said we are repeating the things that were challenging and barriers before, like, if we don't try to change that, like history repeating ourselves because we are just painting the same fence with a different color.
My wheels are turning as I'm processing what you've shared. So first of all, I want to thank you for the clarification and the correction that the CCPs were first imagined, and the guidance was created before the class standards came to play. The guidance that we currently have was last updated in 2010. And since then, there have been changes to the class standards as well. And so there are, I really appreciate how important this historical perspective is in so many different ways. This is a really complex issue, as you note, because there are layer upon layer at a local level to consider, all the way up to national level to CMS, but also there are things that have changed along the way, like the class standards themselves. I have heard from several people the caution that we not repeat the challenges that have happened in the past, and that it is so important that we come together and have a real clear shared understanding of the vision, the intention that started this process back in the 80s. And that's essential as we look into the future. I wonder if you would be able to share a little bit about some of those concrete errors that have happened in the past that we want to make sure to avoid moving forward.
I don't know if I have all the answers to that, but some of the things that, I've done the CCP. In my role in the county of San Mateo, I've done quite a few of them. And, I think it's a big thing, right? So when I put my heart and soul doing those, because I really thought that was a tool to really help move our organization to be much more to look into really how to move the needle in terms of sort of equity. I think if you've never done it, that it takes a lot of people actually to do it. I feel like I was sort of more of the coordinator, because it really looks at our system in many, many different levels: quality improvement, community engagement, treatment, data, policies, right? So really thinking about, like, instead of seeing them as really isolated things, to really think about really merging some of those sort of ideas together so that people are working together, versus like, well, I need a QM data, so this is what's needed, here's the data. Really thinking about how do you approach something where there's really a little bit more coordination. So I think that would be one, because if you always approach it from a siloed approach, I feel like then what happens is one person is in charge, versus really it should be embedded. So I would sort of say that that's one example. I think I don't know if the words buy-in. I think an elevated support from the folks from the Department of Healthcare Services and really understanding this process is a critical one. And I'm not saying that there was no support from before. I think it came for more, it became sort of more of a compliance tool versus more of really like, what's the North Star? That this tool is really posed to really serve the people, or make your organization better to serve the people that's most need, right? So that's another thing, like really trying to engage leadership to understand sort of the complexity of that work. I think feedback is important. In my recollection, we have not gotten so much feedback about the plans that we submitted. My other recollection that there was a conversation that happened when we submitted the last plan, because it has not been reviewed by DHES. They came to us at a meeting, I don't remember when, and said, you submitted the plan, it's been like a year or so. Do you want us to review that plan, or do you want us to just submit another plan? And I'm thinking, for me, in that statement, well, that just kind of tells you like how unimportant that plan was, because you're saying that you've never had the chance to review it, or should we even consider that or submit a new plan? Like that messaging at that time for me, and to the many directors at that time, were like, well, that kind of just tells you like, well, is that really that important when you've not even had the chance to look at it? Again, I'm not making a judgment, maybe. What I'm just saying is, if it's important, it's a priority, it's front and center. So I feel like that's the other part. Like, provide us with meaningful recommendations of, right, or suggestions. It doesn't, again, say that, I remember prior to coming to the county that I actually was one of the consultants that actually reviewed a plan, a cultural competence plan. We had some guidance about what we were reviewing, but I actually don't remember, and I'll just be upfront, whether there was a conversation that we provided that feedback to them. So I remember submitting my assessment of a county plan. I know that there was another person that was reviewing that same plan. I don't know if DHES came together and said, these are the evaluations of your two evaluators. Let's sit down to kind of discuss what can be done. So that's the other piece. The other part is to really embed this in our audit more, right? I don't like audits per se, but I know I looked at audits and evaluations as an opportunity to look at what the things that we're doing well and the things that we could improve on. So we have the triennial, and we also have the external quality review that happens. And over time, really trying to embed the work there also, so that when they come, because of either quality or compliance, that it's embedded, that the folks that are doing the evaluation always also have a historical context and understand the purpose of these things. And then the last one, I think, that in my opinion is important is, often, I don't know how to say it, I want to be more strength-based, that oftentimes we are really needing to change, that we are a continuum of care, that our relationship with our communities is super important, and our relationship with the state and our leaders are also important. But what happens is, oftentimes there's sort of a mismatch in what's important for the community, that in terms of the operations of local behavioral health, and then also the perspective of the HES. So I feel like there needs to be some coming together of those things, of really realistic expectations, right? Because everybody's needs are important, everybody's perspective is important, but at some point, because we know that not everybody will agree with how to do things, how to move things through, is there a common point that we say, we can't change everything, but we can change 90 or 80% of it? And are we in agreement that this is what we're going to do? And so I feel like those are the spaces that we can do it differently. Additional support and TA, I think, is really important for the folks that are trying to understand what this process is. I also think the one thing that's important is systems transformation, organizational change. So consultants that don't just, or work that doesn't say, well, here's how you get the data. It's really technical assistance and say, here's your plan. I will be a person that will help you implement this plan from all levels, right? Because what happens is, you sort of see it in silos. So really the assistance is like, how do you create organizational change so that you embed these practices in all levels, right? In all levels of the organization. So those are for me. And then I think, as I said earlier, how do you measure wellness and recovery, right? So because we're so big there, like, if you go to physical health, diabetes, I get that. How do you measure that? But how do you measure wellness and recovery? And then probably the last one is really, and I was thinking about this last night, is what's the relationship with this new quality improvement strategies that DHS has just released for now public comment, and the overlap, if not such a big alignment with the cultural competence plans.
I value so much that you speak directly and you speak authentically, both from the experience of having completed several CCPs, but also the unique perspective of having had an opportunity to talk to many people who have been involved in the CCP history to this point. And you bring these two together in a way that is very unique. And I think so much of what you have just shared, we're hearing themes across these different listening sessions. We hear just at the first level around overlap, that some counties, you have an MHSA coordinator who is separate than an ESM. And some counties, it's the same person. But when you have a 3-year MHSA plan and you've got an every 3-year CCP, and I mean, there's just, we have also heard from respondents, especially among the ethnic services managers, around is the CCP a plan or is it a report? What is the utility of it? How are we supposed to use it? So back to that initial comment you had made earlier about the tool, and thinking about how does the guidance set us up for the output to be either a plan or a report, and where is there potentially some repetition that can be removed, because ultimately the utility of a plan that is several dozen pages long versus several hundred pages long is really significant. The extent to which anybody can access and utilize a plan that is so long you really need some time available for that. And who has that time? And then I think also to that really important point that you brought up, Jay, I'm so grateful that you said this. What does health and wellness mean? How is that different across our different communities? And how is that different in 2022 versus 2018? What does it mean right now to have health and wellness when we have such major variables like the pandemic, like wildfires and storms that are exacerbating the existing social inequities and behavioral health inequities and disparities that our communities are facing? I wonder if you could talk a little bit about, well, you were talking earlier about having that flexibility, both for the local dynamics that are going to be unique across counties, but also when the environment that we're working within and living within has such significant changes. I mean, just in this last year, I can say we've had to think about the Omicron surge in the last month and how it's affecting the extent to which people can come to our listening sessions. I'm thrilled to say that we had 74% of registrants actually show up for the events. That tells me how important this work is to people who are experiencing staffing shortages in this last month, that they continue to show up. But I just wonder if you could talk a little bit about that, like flexibility in terms of those multiple kinds of variables.
Yeah, well, I feel like, again, so the other thing that I was sort of thinking about, can you really, and I don't know what the answer to this is, is 3 years really can you really transformational change, does it happen in 3 years, right? And so I often wonder, like, well, how can you measure transformation that really is big, and is it 3 years? And I think that's what's happened. It became sort of more of a compliance issue versus really saying, like, this is the tool that really will help us be much more accessible, be much more really aligned with our clients' needs, our families' needs. But also paying attention to the shifting system challenges that's happening, so the ability, for example, to pivot, because most behavioral, or if not all local behavioral health, in addition to continuing their operations, had to support our public health to do COVID response, right? And how is that affecting our operation? How is that affecting our delivery of care, right? So, I mean, you have a workforce that's super exhausted, right? And really, are we taking that into consideration when we just, respond to, well, what are you doing to support your workforce? I mean, that's something that necessarily the county can't answer, right? It's a statewide conversation that really is needing to happen. So I feel like, are there parts of the criteria that really are higher level conversations? And then helping as we develop, what will that look like, become much more specific tools that counties can use to say, well, that indicator works for me or is aligned with my county. That strategy will work for me, so I'm going to try to use that and see in the next 2 or 3 years if that's going to be effective or not, right? And I feel like that oftentimes is not the question, of more like, well, just submit a plan, gets your numbers, let's do the intervention, let's submit it, versus more, with what we have, is that really going to change the needle? Let's try it out. Like, I feel like this cultural competence plan is really a quality improvement plan to some degree, because it's testing, it's getting information, it's testing your hypothesis, and then saying, well, that really made a difference. We engaged a little bit more better in one community, but that didn't fit well with the other one. So we need to pivot a little bit, right? And not this sort of plan. Again, I don't see it as a report. I think it's a plan that really we look at every quite often and say, are we sort of following the guidepost? Where are we at in the guidepost? And then, so I think that would be where, but we have, I mean, climate change, the effects of climate change with mental health and substance use services. When we have clients that are coming in because of wildfires and their smoke. We had, for example, folks that, I can't go out of my house, right? Because it's too smoky. Or my kids are not coming to school, are not going to school because schools are closed because of the smoke. So I can't go to my appointment. Or I have poor broadband. My internet can't support. Or there's 10 people in my home, I don't have any privacy. I mean, so because everybody's here because of, whatever. So I feel like that's the piece. And then I did want to say, if I could return back to the conversation, is the plan, as we're sort of seeing the shift in the delivery of services, should really focus on really integrating the work, right? So substance use and mental health. And even at this point, there are still plans that are separate. And for me, well, we've kind of tried to work towards that. And yet still, years after, people are submitting a different, SUD plan that's more class-based. And then a mental health plan, which is more CCP-based, or cultural competence plan. So I feel like that's the step is, what will this look like if we're integrating, not just in terms of clients and data and all of that, but really organizations, like what are you doing? And then again, the next one for me is aligning it with some of the CalAIM changes that's going to happen. So it doesn't feel like an extra additional thing. It's sort of more like we are really trying to align the systems together.
I just appreciate your brain so much. I love that you are inviting us to think about, let's go back to the basics here. And earlier you said you highlighted the idea around among ethnic services managers and among behavioral health directors as well, that there are people who've been here for a long time. And there's also a whole new group of people who are coming in who are interpreting what's currently written in different ways. And it reminds me of a phenomenal interview that you had with Rachel Guerrera, who we mentioned earlier, really as leader from the very beginning of the CCPs, where she talked about the idea of the terminology, even just at the level of cultural competence, so I appreciate that you were inviting us to really step back and think at even fundamental levels of, and Rachel did as well, like, what is the language that we're using here? To what extent does it map on to the reality and what we know today in 2022 about health disparities and increasing access to health equity, and maybe not access to health equity, but the manifestation of increased health equity. And how is that defined? And how is it defined by community? How is it defined by ethnic services managers? How is it defined by behavioral health directors? And frankly, I was also hearing part of what you're talking about here, the importance of a growth mindset, that we are engaging in a process. You said looking at the guideposts. Well, in order to look at the guideposts, that means that we need to be involved in some kind of a regular reflection process to say, okay, this is what we think that we're working towards. How is it actually panning out? And having the ability to kind of course redirect. And you talked about this was that basic block that you mentioned. We have it set up on a 3-year cycle right now. Is that the amount of time that makes the most sense to be able to see change? What kind of change might we see within a 3-year period? Or do we want to really invite ourselves to think more expansively at that very fundamental level and the assumptions that are in place with setting up certain terms or certain timeframes, that we be invited to think on that level? I also really appreciated what you were talking about. I feel a little bit like a bobblehead, if you're familiar with those little things that people will put on their dashboards, because I'm like in agreement with you so much of what you're saying. But this idea of if we create what if part of what we really value in addressing health disparities and working towards health equity is the celebration and the value of that reflection and course redirection? What if we are focusing even more there to say, we know that there are variables that are changing significantly with things like global warming or the pandemic, especially when we step back and say, okay, we know that higher rates of diabetes, higher rates of asthma, different predisposing health disparities that lead to worse outcomes, both in physical health and mental health and behavioral health, are communities of color, LGBTQ plus communities, communities with fewer access to, limited access to economic resources, are people who are experiencing houselessness, like these different communities are going to experience these variables at a magnified level. How are we creating and responding to these changes? Because maybe that it's that we know from the class standards that the recommendation is that we are involved in a regular reflection process and that we are course redirecting, that's normative. It's not a bad thing. That's actually really, that's what you want, because we know that there are going to be so many unique variables. We have to think about it on a local level. We have to think about it on an individual community level. And we have to think about it in terms of the larger context, which right now is changing quite a bit. So I really appreciate that you talk about that. I know because I have heard from, we've had, let's see here, over 180 people who have attended our listening sessions to date. There is some phenomenal work that is happening at the county level. There is a lot of innovation. There is a lot of really incredible partnership between CBOs and counties where people are thinking very critically about shared power. You can say it's important to bring these two together, but then how do we do so in a way so that people really are able to sit and make decisions together and there are dynamics at play. I wonder if you might talk a bit from your perspective about some of the really exemplary dynamics that you've seen at any point in the state, because I think that's the other piece is when we start talking about CCPs or anything about wanting to make sure that we're able to celebrate and acknowledge that there's really great work that has been done. We're not starting from zero. California has for a long time been on the forefront of change in the nation. And it's a great opportunity to kind of highlight some of that, if you would, please.
Well, I mean, there are 58 counties and, and city, and then a couple of cities. And so I feel like there's really a shift that's sort of happening. We're looking at really how do we engage more people with lived experience as really part of our systems of care, creating more, accessibility. Some of the invisible communities like LGBT communities are starting to be elevated in terms of really understanding, the complex and unique, oftentimes invisible needs, partnerships with, non-traditional behavioral health providers, really in a different way. I mean, there's just so much there, I feel like, but I do think my point is that we need to really come together and really be clear about the expectations, because oftentimes in meetings, whether it's with CBOs or partners or different, that I know that our hearts are going in the right place, but there's just seems to be a difference in opinion on like what we can do, what we're allowed to do, what they're expecting. So I feel like some clarity about that would be important. I also will re-emphasize now the importance of really doing great data collection, data that can speak to each other, data that is standardized. Because one of the things that we see now is for us to be able to move these metrics, is the data that we're gathering accurate? Can we really look at the data that can give us some analysis and trends of what we're seeing? Is the data really aligned with the stories that we're hearing or vice versa? And oftentimes there's really a disconnection there. And so I think the infrastructure for me, as you're asking, like, what can we do? We need to build a foundation, right? Data collection, speaking together. Are we looking at the same data? Are we using the same data? And if we're not, that for me is critical as we're trying to compare, because it's not each county doing its own work that's important. It's California all together saying, well, here's the metric that has changed, right? And so I feel like that really is sort of the point, the point. And I'll just sort of say that, and I'll challenge us a little bit. Oftentimes, who gets to be participating in many of those community meetings? The people who are able to have flexible jobs, flexible hours, don't need to think about childcare because they can attend those meetings. Probably some that maybe are educated and comfortable speaking English, that know Robert's rules and all of those things. And I wonder, are they really the right people sometimes? Because in many of the conversations, it's the same people that show up that say that they represent the community when maybe they represent only parts of the community. And I wonder, how do we change that? So for me, that's a clear metric. Like, are the people that really is engaged with you the right people? Not the same people because they're able to, or they are the strongest, loudest voices.
I think about some of the really exemplary work that CRDP is doing, creating institutionalized course redirections with power dynamics. So as just one example, they have a committee where they always have one of the co-chairs is a community-based organization. So they are building into the structure a position where they're ensuring that the person who is leading the meeting, who is setting the agenda, who is has power, a distinctive power there, is intentionally a person from a group that historically has not had access to power in that space. That there, and so I think it's a very elegant and concrete example of how how it can be helpful to think about institutionalizing shared power. It doesn't get to that earlier point that you were saying of like, how do we make sure that people are able to even come into the conversation? And I think that this is a multifaceted piece. I know that for ourselves in the listening sessions, we invited people to come to our listening sessions, but we're now going out into existing community meetings, and we're hearing qualitatively different information in those meetings that we're getting to. Some of those people that weren't able to come to our meetings before, there are reasons for that are really important for us to hear about, but that's also still not enough. We need to hear from the people, to your point, who aren't even making it into those meetings in the first place. We're at our time, and I want to be respectful of your time, but I just wonder if you might be open to it. I would love to hear additional thoughts and examples of how we might make sure that the people who are not being heard historically are intentionally brought into this process, because it's going to be a community effort to overcome some of these.
I mean, I think we have a lot of colleagues that have done more work in this field. So I sort of, as you know, encourage you to kind of talk to them. I think maybe if, you know, as you're asking me about a shift in my final comment is, we really are at a point of really transforming our systems. And so I want us to approach this with mindfulness and really intentionality, and really look at like what kind of radical transformation. I'm using the word radical because I do think we do need a little bit of radical transformation, because some of the things that we've done, I'm not saying that they were not successful and they didn't make a difference. I think that's just the urgency and the need to really change it is necessary. I think we have a good opportunity with really leadership in multiple levels and all levels, from the state, from local behavioral health, from the communities, that say it's time. We really need to do something different. And so I want us to really sort of be open-minded about that approach, that we really are kind of needing to be much more bolder in some of the strategies or some of the opportunities here, and not be held by, well, that's not how it's done, or we have a deadline to make, or you know, that's going to take 5 years. I mean, I feel like change that will happen in 5 years starts today. And so, you know, I'm asking, I'm inviting for the people that will be watching this to have said to me in public, well, Jay, that change takes 5 years. So why can't we just figure out change that we can happen now? While I agree, the transformational change that really needs to happen today, that maybe you're envisioning that can happen only 5 years, needs to happen today. Because if not, we are coming back at the same place again and again and again. And at the end of the day, it's really people's lives that are going to be affected.